Absolutely. You brought us on really to the third question about what trust should do to encourage staff to raise concerns, including whistleblowing, as well as taking ownership for solving the problems when they spot them.
Well, we did talk quite a lot about that, and the word authenticity came up quite a bit again in terms of there's no point having written processes that say we're encouraging staff to raise concerns if the staff feel that they're then going to be punished in some way, or if they're going to be treated inconsistently between functions. And so there's something about the overall culture of an organisation that I think does get influence from the leadership of that organisation that needs to be authentic in its beliefs that safety and quality are the highest priorities. So things like non-punitive approaches and trying to create learning environments from this are really important. I mean, the second point we made was that this is really about a continuum. And whistleblowing, we didn't really particularly like the language, that we should be getting into the zero tolerance around some of these very basics. We've been accepting the unacceptable now for so long in areas such as taking basic vital sign observations at ward level. Very very unreliable processes for that. Anthony had a list of things that he had. But where did it all go wrong? All this, it seems to have crept in that we just turn a blind eye or we go deaf to the cries of the patient. And so somehow we've got to get that rigorous restoration of those professional standards and then ensure that we're consistent in our lack of acceptance of breaches of those standards. And then the third thing we talked about was, that this language of whistleblowing is probably it isn't very constructive. We need something about raising concerns processes, but more importantly, we need a culture that we create through leadership that's receptive to learning from those concerns and resolving those concerns. MPSA have a variety of approaches that they publicise for how you can get staff to raise concerns, be in awe, etc. So I don't think it's the mechanical bits. It's the actual culture and leadership that's key to this.
Mm-hmm. Let's do two things that have come up from other seminars that link to this. One was the idea of having an independent director on the board that staff could go to if they wanted to raise concerns and bypass the sort of the management hierarchy. Is that something that you think works?
And certainly in our concerns procedure in my last hospital, we had a panel of trusted people, including the chaplain. I think somebody mentioned the clergy earlier on, who could be approached if a member of staff didn't feel they were getting anywhere within their own line communications. And certainly I said lots. If you have concerns that are not being resolved, raise them with the chief executive as a kind of final player. It's actually quite hard as a chief executive to get concerns raised formally, and clearly raising concerns formally to a chief executive, bypassing existing channels, takes a lot of courage. It takes a lot of courage to disrupt your normal line management arrangements, your normal peer arrangements. So I think chief executives have to handle that pretty carefully as well. So an independent director I'm not sure about, but to me it's about all the leadership and the process the leadership put in, being there to try to handle this encouragement of concerns being raised in a non-punitive way.
It's a bit of both and. There's a sort of supporting and open and enabling leadership on the one hand, but zero tolerance for the hang-up offences on the other. Okay, and other points that people want to raise about this one?
Yes. It was really just that I think professionals sometimes raise concerns outside of their own organisations, and we have to recognise that they will talk with their peers, they will talk with their professional bodies, and certainly we've had experience at the college of people coming to us with concerns that they have about their own organisations. Now, what we would say is you should work within your processes and really try and be part of the solution and not just sort of sit on the sidelines calling it, basically. But I think that then the professional bodies, and I think the RCN's the same and the GMC's the same, that things come into us where in fact we can then feed them back. And that may be a safer way that sometimes people raise concerns. And we've certainly had that, and we've gone back to have had conversations back with medical directors and chief executives where somebody has not felt able to raise it within the organisation. But I think we have to be completely knitted in then back with the organisations
It does sound that from what you're saying that the concerns could be raised in a number of places outside the organisation.
I think they can be, yes.
Is there a danger that patterns might be missed?
I'm sure that there is. In a way, I'm not necessarily advocating it, but I think de facto it happens. And I think strong professional networks, but with a sense of responsibility that in fact something has then got to happen. You can't just sit there moaning about it, you've actually got to do something. But I think that it isn't just organisations where this happens. I think actually things are raised outside.
Okay, thank you. Suzanne, and we'll move on to the next question.
One point from leading on from that is that learning has to be at the closest point of the delivery of the care. We always say about our national system, it only collects something nationally so that we can influence the system nationally. It does not replace local incident reporting, which is incredibly important. But there are some really nice ways that people do in learning from an incident that's happened, which is an open root cause analysis, where you'll have an open week where people can just come down and plot their part of the journey towards the end of that incident. And it is very, very constructive and very proactive about picking out lots of things that might have been missed. And it's open to the entire organisation, so anyone from the porter to the chief executive can walk in and say what part they played in that incident.
Good. Okay. So,
very quickly, just listening to this discussion, a lot of it's being done unto organisations. We were talking on this table about whether it's possible for an organisation to recognise what line of business it's in, to try to devise for itself how it wants to monitor. And because if it's doing it to itself, it's much less of a threat and of a blame culture.
Can I finish off the whistleblowing thing? I think you've got to make the whistleblowing real for the organisation rather than having a policy. For example, in our trust, the non-execs do sessions in the evening, the daytime, for any member of staff to come and raise concerns. And secondly, we should champion whistleblowers. We should actually recognise what they do within the organisation, where they thank that board, where they get a letter saying this is what you've done, this is the benefit for patients. We should actually champion what they do.